Rural counties in California often feel neglected by state agencies. A recent report by the California State Auditor indicates that when it comes to access to quality medical care through Medi-Cal, residents in rural counties may not be getting the same access to quality health care that other Californians enjoy. What were the findings? We'll ask California State Auditor Elaine Howle.
BNSF Railway, moving our economy for 160 years. BNSF, the engine that connects us. Additional funding for the Maddy Report made possible by a grant from The Wonderful Company, harvesting health and happiness around the world. From the California Channel at the State Capitol and the Maddy Institute, it's the Maddy Report with Executive Director of the Maddy Institute, Mark Keppler.
Welcome. California's 18 rural counties often have the feeling they're being left behind, and they lack attention and service that they receive from the state, at least compared to large urban areas. A recent report by our guest, California State Auditor Elaine Howle, indicates there may be some truth to that when it comes to state oversight of how Medi-Cal is being delivered to many of California's rural residents. Welcome back to the Maddy Report.
Thank you.
So, just as a reminder, can you briefly describe California's Medi-Cal program? Who benefits? What does it cover?
Sure. So Medi-Cal is basically a component. The federal government has a big program called Medicaid, and it's intended to provide services to individuals who are low income, aged, disabled. In California, that component is called Medi-Cal. It's a significant program in the state of California. It covers up to 13 million people in our state.
It's one of the biggest parts of the state budget.
It's one of the biggest parts of the state budget. The state of California, our general fund provided $19 billion in fiscal year 17-18. The Medi-Cal program is $100 billion. The federal government provides a significant amount, but the federal government is going to start reducing the percentage it provides, so the state's costs are going to go up.
And the number of people on Medi-Cal has increased substantially.
Right. It expanded substantially under the Affordable Care Act, where there was Medi-Cal or Medicaid expansion. The state of California participated in that, so we went from 8 million to over 13 million people participating in Medi-Cal.
Okay, so just to put it in perspective, you said we talked about the fact that it's a major part of the state budget, and you said $19 billion.
That's right.
Of a state budget of about, what, $107 billion for Medi-Cal.
Just for Medi-Cal,
and
yes.
so, yeah, so, and the federal government has been paying at a high percentage, but they're starting to dial that down.
That's correct.
And my recollection was I think they're dropping it down to 90% of the cost by 2020.
That's correct.
Okay, so more on the state. And
Right.
they think that cost, by dialing it down to 90%, is going to cost the general fund, the state general fund, about $1 billion a year.
Right. So legislative analyst that does budget analysis for the legislature, yes, estimated that it'll be an additional $1 billion cost to the state of California as the federal government reduces the percentage that they are going to provide.
That's a lot of money. So, okay, how is Medi-Cal administered?
So Medi-Cal is administered by the state of California Department of Health Care Services, but as you might imagine, most people are going to be living out in the community, so the state of California works with local county welfare offices to provide services to individuals. So the counties are accepting applications from potential beneficiaries. They're responsible for determining, is this individual eligible for Medi-Cal benefits?
That's the first point of contact.
Exactly. So the contact is out at the local level. Right. The counties are reimbursed by the state of California administrative costs. That costs the state over $2 billion in administrative costs.
That's a lot of money.
To pay the 58 counties to administer the program locally.
Okay, so what's the reason behind, there's been a shift now in Medi-Cal from this fee-for-service model, where you pay for everything you get, to a managed care program where you just pay a monthly fee and they just take care of you. Why the shift?
Right. There's a variety of different reasons. One is better care as far as coordinated care. You're going to have a primary care physician providing a variety of different services. It's also much more cost effective. So you're paying, as you said, the state of California is paying a monthly or capitated rate, a monthly rate to a health plan, and then the health plan goes out and gets different providers to provide the particular medical services to beneficiaries.
Right. So it sounds like in a managed care system, their emphasis is on prevention, right? Because if you're the healthcare provider and you're keeping people healthy, they're not using your services. You're making more money.
Right, exactly.
So that's very different than the fee-for-service model, where it's kind of almost the exact opposite, where you want people to use the service. So the incentives are completely different.
That's correct.
I hope I made myself clear on that.
Yes.
Basically, on the preventive side, it's more of a focus on the preventive side.
And there are other states that have been really moving towards a managed care model for the very reasons you were discussing. It's more cost-effective for states, and it seems to be a better situation for beneficiaries as far as getting services.
Okay, so this change is made in California, and the rural counties are dealing with it. About a third of the rural counties adopted for a nonprofit healthcare plan called the Partnership. Can you briefly explain how that plan works?
Right. So Partnership Plan is a health plan. So they basically have 8 counties out of the 28 rural counties that were encouraged to move towards a managed care model. So these 8 counties basically partner together. They have a health plan called Partnership. So all of the counties are able to share in the costs of establishing that plan, and then that plan goes out and, again, contracts with providers. So it's a managed care plan that serves beneficiaries in 8 counties.
Yeah, but 2/3 of them didn't go that way. The rural counties, they grouped under a new healthcare model, they called it the regional model. How's that different? Can you briefly describe that model?
Correct. The regional model was, there were 28 counties. 8 went with Partnership. There were 2 counties that were big enough to have their own
I
model.
approximated.
So we can eliminate those 2.
Right.
So that leaves 18 counties, relatively small counties, that were kind of left to their own devices. So what do we do here? So the state of California established a regional model for those 18 counties, and basically what DHCS did is contracted with 2 plans, Anthem and Health and Wellness, and then those plans provide, contract with providers. So it's kind of an 18-member plan.
Okay, all right. Well, the Legislative Joint Audit Committee asked the state auditor to evaluate the level of care provided by these different models for California's rural counties, and they found that there's a pretty different approach between the two. That conversation in a moment. This is the Maddy Report. Welcome back. I'm Mark Keppler with the Maddy Institute. Our guest is California State Auditor Elaine Howle, whose office recently issued a report on the level of care being delivered in California's rural communities under the state's Medi-Cal system. So one of the issues here is acceptable level of care. Is that defined under Medi-Cal?
It's not specifically defined, but there are different components of acceptable level of care. So one is access. Do beneficiaries have access to a physician, to a provider? And then if they do have access, what's the quality of that care? Are there preventative services being provided? Is there appropriate follow-up? Are they getting the appropriate medications that they need for their particular condition? So we broke it down into 2 different components. First of all, access. Do I even have the ability to see someone? And then quality. Are those beneficiaries getting good quality care?
Well, let's see if we can break down access a little bit more, in more detail. I mean, do you specifically define what constitutes adequate access?
Right. So the state of California actually established some parameters. So what it requires is there should be access within 10 miles or 30 minutes. Now, it may vary based on certain specialties. It may be longer than that because maybe 60 miles or 60 minutes. So what we try to do—
But not 2 hours or 3 hours.
No, it needs to be reasonable, particularly for individuals in Medi-Cal, because you're looking at low-income individuals, disabled individuals, don't have the ability potentially to travel very far to seek care. So we really tried to determine whether or not individuals had adequate access to care in those 18 counties.
Okay, so you've got these 2 Medi-Cal delivery systems for rural residents, the Partnership and the regional model. Most are under the regional model. And your findings were that the Medi-Cal beneficiaries in the regional model did not receive acceptable access to care. How so, and do you have some examples?
Right, absolutely have some examples. So when these new standards went into place, Department of Health Care Services wanted to give health plans an ability to kind of get used to the new program. So they said, if you demonstrate that you have tried to identify a provider within the 10 miles and you can't do it, we'll allow you an alternative access. So it could be 30 miles. But what we saw is Partnership typically was within 60 miles. For health and wellness plan and Anthem, some individuals—
Which is that regional model.
That's under the regional model. Those are the 2 health plans under the regional model. Beneficiaries under that model, if they're with Anthem and they need to see a cardiologist, you have to drive 230 miles. If you're under health—
To their specific provider.
To their specific provider within that plan.
Right.
Health and wellness, it was a little less than that, but it was still
250 miles. I mean, it's—
to see a cardiologist. There were some where it was oncology, and you're going to have to drive 300 miles to see an oncologist. Those are not acceptable standards, because most of those individuals are going to say, forget it, I can't go that far. I'm not even physically able to do so, and I can't afford to travel that far.
Right, because you're also dealing with low-income people in this situation. So, so they live in these rural areas, or they have to travel these long distances, and is that just— why is that?
Well,
because they limit the number of providers?
Well, part of the problem that we identified with the regional model is the state did try to contract with additional plans. They only identified Anthem and Health and Wellness that met the criteria. But what what the problem is there is if a provider is with Anthem, they're typically not going to be a provider with health and wellness.
Okay.
So some of the beneficiaries under Anthem, the example I used, they have to go 200 miles to see a cardiologist. If I'm under health and wellness, I go 120 miles, or maybe it's only 20 miles. Right. So partnership has the benefit of it's one plan, and they have all their providers under that one plan. So there's more opportunities for beneficiaries to seek care closer to home.
Yeah, the other thing you were mentioning earlier, and I think it's kind of, I want to underscore, and that is it's not just a matter of inconvenience here, is it? It's also a matter of whether these beneficiaries are actually going to get the care, going to go and try to get the care, right? It's just
right.
too far.
Right, exactly. It's too far. I'm a low-income individual. I can't afford to take off work for 2 days to drive 200 miles to seek care, spend the night, and then drive back home and go back to work the next day or a couple of days later. So they may just not even seek the care. And then they'll end up in an emergency room, unfortunately, and then that's more expensive for the
exactly.
state.
So if they follow the logic, if they end up in an emergency room, much more expensive.
Exactly.
So just by not taking care of this, providing reasonable access, it's actually exacerbating the problem and the financial cost to the state.
Right, and one of the important components of a managed care program is, as you said, preventative care. You want people to have access to providers so they stay healthy.
So what did the state do? Did they do anything to kind of make sure when these regional model health care plans didn't meet access requirements? Did they step in and say, hey, you got to provide access, reasonable access?
And that's a concern we had with the Department of Healthcare Services because they are responsible for approving these alternative standards that these plans were submitting. What we didn't see is due diligence on the part of Healthcare Services saying, okay, show us the evidence of trying to identify additional providers. And they didn't do a very good job of holding those plans accountable. They have stepped it up recently where now they are suggesting to these plans, you got to come up with a corrective action plan. You've got to identify additional providers, hopefully for your beneficiary. So at first they did not do a very good job.
So they weren't really showing that they evaluated all the possibilities here.
Exactly.
They kind of just were shortcutting it. So you think the state, so what else do you think the state could or should have done to deal with this problem of access?
Right. Another option that we believe the state should have considered is allowing some of these beneficiaries to go out of network. Okay. So if the plan can't provide a cardiologist within, say, 60 miles, and you're suggesting to a beneficiary you got to drive 200 miles, no. That plan should be willing and should be forced by the state of California to allow that beneficiary to go to a provider who's out of network. Maybe it's a provider under health and wellness, or maybe it's a provider that's not even part of Medi-Cal. Pay for that care out of network.
Okay. Well, it's not just a question of access, it's also a question of the quality of care provided. That conversation in a moment. This is the Maddy Report. Welcome back. I'm Mark Keppler with the Maddy Institute. Our guest is California State Auditor Elaine Howle, whose office recently issued a report on the level of care being delivered in California's rural communities under the state's Medi-Cal system. So what about the quality of care in these rural communities under this regional model health plan that so many of these rural counties are using?
Right. What we found is the quality of care is not as good as other counties in the state of California. So there's different measures, there's different performance metrics that the Department of Healthcare Services requires plans and providers to meet. And when we were looking at some of those, we found that when we compared the regional model counties, these 18 counties, to other counties in the state of California, they were scoring much, much lower in some of those performance metrics. And some of the types of things are preventative care. Breast cancer screening is one example, preventative care for children, and they were not hitting the mark as far as making sure that those services were being provided to beneficiaries.
Yeah, and I think you said that the Department of Managed Healthcare did an audit, and they identified serious deficiencies in some of these situations, these regional models. So your report, though, did say that things are getting a little better, at least recently.
Right. Recently, I mean, some of the audits, what the result of an audit is again, you identify a problem and you want the problem to be fixed. So what the state of California requires the plans to do is to put a corrective action plan together, and with timelines. How soon are you going to be able to identify additional providers, make sure the providers are providing the appropriate preventive services. So with those corrective action plans, the healthcare plans are basically put on notice. We are following up on the monitoring that we've done.
Well, let me ask you this. You know, in your report, you were critical of the limited guidance that the state was providing these rural counties when it comes to making this transition from fee-to-service to managed care. But the state seemed to push back a little bit when they responded, and they suggested, hey, their approach has worked in the past. What's the problem? Right.
So Healthcare Services did disagree with us on this particular issue. Basically using other counties that have gone to a managed care model, and those have been relatively successful. Those are some of the bigger counties that have more infrastructure, have more staffing, have more resources. We're talking very small, rural counties. And
you probably got one
believe,
person wearing 6 hats.
Right, and the Department of Healthcare Services, when we talked to them about this, said, well, there's all kinds of information on our website. No, the state of California needed to be more proactive in working with these small counties to help them figure out what model would be the best model for beneficiaries in our county.
You know, it's a very important topic. That's why we're spending some time on this show. But I will tell you, of all the topics that I researched, water and healthcare are the most complicated topics.
Very complicated.
And so you expect a small county with one person that's doing 6 or 7 things to know this technical area is asking a lot.
That's I agree.
So you suggest in the future the state should assist rural counties in this transition to what you call county organized health systems. What is a county organized health system, and how would that be an improvement over the regional model?
Right. A county organized health system is similar to where the counties would basically band together. They would develop a healthcare system that the Board of Supervisors or the county board would be involved in some of the oversight of that health plan, so the county would be more actively involved in decision making with respect to the structure of the plan. It's just a better situation for the counties themselves, because now one small county is not having to decide, how do we go about? We're working together with
it sounds a lot like the partnership model.
Very similar to the partnership model, where they had 8 different counties come together, and that's a much stronger model than individual counties trying to figure out what they can do.
So you also note that this transition from a regional model to this county organized health system, kind of partnership model, can't happen overnight. What is the county going to have to do if they want to change from a regional model to this improved model? What do they have to do to make that change?
Right, so the counties would have to figure out some of the infrastructure, the staffing, what other services they need to be able to provide, basically a startup. Right. But also the current regional model has contracts with Anthem and with Health and Wellness. They have to; those contracts have to
finish
expire.
Those contracts,
so Health and Wellness expires next year. Anthem is through 2023. But we think the Department of Healthcare Services needs to work with these counties and really help them figure out what infrastructure do we need to get together and put in place. If we need additional resources, take the lead, DHCS, Healthcare Services, and seek funding from the legislature so that we can create a model that really works for these counties.
Yeah, and I think that what you're asking them to do is not to be reactive, but to be proactive, right, with these rural counties.
Right, start planning now.
Yeah,
long before the contracts expire.
And I was reading your report, and you're saying, you know, there's a lot of activities that have to go into this. This doesn't happen overnight. So you've got to establish a special commission, you've got to hire administrative staff, you've got to get federal approval. Anybody going through a federal process knows that doesn't happen overnight.
That's right.
All right, so some advance notice, and so you start getting to it. So what are some of the other ways that the state can improve access to quality care for Medi-Cal recipients in these rural counties? The state auditor has some more ideas. That conversation in a moment. This is the Maddy Report. Welcome back. I'm Mark Keppler with the Maddy Institute. We're talking with California State Auditor Elaine Howle about the level of care being delivered in California's rural counties under the state's Medi-Cal system and how we might be able to make it a little better. So one thing you'd like to see happen is for the state to make health plans exhaust their options regarding access before seeking an exemption. And you listed several recommendations. What are they?
Right, so we had a variety of different recommendations. This is trying to really clamp down on these access standards that DHCS approved for all of these different plans. So first of all, develop written guidance that really specifies for healthcare services staff and for the plans exactly what you're looking for when you're determining whether you're going to approve an alternate standard, whether you're going to deny it.
Get some consistency if you have a written standard.
Exactly, and understand what the plans understand the expectations, healthcare services staff understand what they need to do to make that decision to approve or deny. In addition to that, determining a specific number of providers that have to be contacted.
Give them a target.
You've got to prove to us that you have reached out to a certain number of providers and they have said no. And we, as a state of California, need to see the evidence that you have actually tried to do that rather than just saying it's difficult. Approve our alternative standard. The state was way too soft. And we want to see evidence of them contacting. So don't just give us a list of providers. Tell us when and who you contacted. And then the state of California should follow up with some of those and contact those providers and say, it's our understanding that you were contacted to participate in Medi-Cal and you refused. Yes, or is that correct or not? So that puts the plans on notice that the state is basically checking to see that that's happening.
So another thing you'd like to see is proof that beneficiaries in the regional model counties, I guess they still exist, have reasonable access to medical care. How can the state do that?
Well, again, the state can do that by clamping down on the access standards, but also making sure that
Because they
we're
were giving
monitoring.
those away, it seems like.
Right.
Easily.
I mean, they approved over 10,000 alternative standards,
Okay.
and there were 1,000 of those were associated with the 18 regional, the regional model
Again,
counties
with the
that we
regional
talked
model,
about. So really trying to reduce the number of those access standards that are being approved, so beneficiaries do get access to providers and can get access to preventative care in addition to any other care they need.
The other thing you talked about was giving counties a sufficient amount of time if they're going to change their managed care models. You know, moving away, say, from the regional model, give them time to make that transition.
Right, exactly what we were talking about a few minutes ago, where there's an existing contract with Health and Wellness, an existing contract with Anthem. Let's not wait until those contracts expire. Let's start talking to the counties, being proactive, as you mentioned earlier, in determining what do we need to do to put together a better model for these counties. So working with the state of California working with these counties.
You know, it looks like from their response, the state's response, Department of Health Care Services response, that they agreed with most of your recommendations, but not all.
That's correct.
So which ones were they unwilling to implement, and why?
Right, so one of the things we suggested is you've got to help the counties identify additional providers, and Department of Health Care Services says, that's not our role, that's managed care, Department of Managed Care, there's another agency, OSHPD, that's responsible for that as well. And we said, wait a minute, no, you are the entity in the state of California responsible for the Medi-Cal program.
The buck has to stop somewhere.
You should be helping identify
Right.
additional providers. In addition to that, they were saying if the counties feel they need money for a COES model,
Right.
they can go to the legislature. No, the Department of Health Care Services can be the central agency that assists the counties, works with the counties to determine what is needed, and then present that information to the legislature. They're better positioned, so we disagree with healthcare services there. And then the last issue was about the timing. We talked a little bit about it.
Yeah, give them some time
It's
to-
up to the counties to figure out when they want to do this. No, we need, as a state.
Again, the same problem. The rural
Right.
counties don't have the information or knowledge or experience to do this.
Right,
State
they
can
don't
help
have
with
the
that.
resources to do that. The Department of Health Care Services, big agency responsible for Medi-Cal, they need to do it.
So how optimistic are you that this whole move from fee to service to a managed care model, a better managed care model, will result in better quality and better access to health care for these people who live in California's rural counties?
Well, I think that the fact that we did the audit report, that members of the legislature were very interested in this particular audit. There's a hearing that's going to be held in November of this year. So I think moving to managed care has been successful for other counties. We haven't done a very good job as a state with these smaller counties, and I think the state of California needs to step in and do a better job.
Well, thank you for your work in this area, and thank you for joining us. Again, thank you, California State Auditor Elaine Howle. If you want to stay current with state and local politics, you can log on to our website at maddyinstitute.org. This is Mark Keppler for the Maddy Institute. Thanks for joining us.